So, excellent talk by a good friend to Natasha, and I'd like to call upon the panelists. I think Dr. Vijay, Akhil, and Dr. Sameer, right? And if Dr. Kumar is also around, maybe he can also join. Thank you. So in the next 20 or 25 minutes, we'll try to see if we can attempt to improve outcomes in EGFR-mutated advanced non-small cell lung cancer with what I would put it as TKI plus treatment strategies. We have been through this era where we used to get positive EGFR positive reports on either biopsy specimens or cell blocks and be very happy at getting either an 58 or an exon 19 inhibition, and that is understandable, as were the families. And we have gone through the eras where we used to have very good responses visible on chest radiographs in addition to clinical improvement. And again, excellent responses if you looked at CT scans after some period of time, clearance of multiple hepatic metastases and liver metastases. We are also aware that EGFR is the commonest oncogenic driver alteration, around 30%, along with ALK 10%. So this is also in line with what is globally known, that exon 19 deletions represent 2/3 of the EGFR mutations, L858Rs approximately 1/4, and then you have this small distribution of exon 20 insertions, the uncommon mutations, de novo T790Ms, and the others. Dual mutations are there in approximately 3 to 5% at baseline. So we have this background fact that they are the commonest druggable targets, a prevalence of approximately 30%. This data that is probably even higher in certain specific geographical locations within the country. And we know that treatment with an EGFR targeted drug is more effective and better tolerated than standard platinum doublet chemotherapy. And we have several first generation, second generation, and third generation drugs available, as are multiple combinations of TKIs with other targeted drugs, especially VEGF inhibitors, and with chemotherapy. Now, this is what the real debate has been over the years: the best treatment option first, or the sequencing of treatment. And the first relies on the presumption that patients may not get second-line treatment at progression, and that the most effective treatment given earlier achieves greater progression-free survival and perhaps overall survival, compared to reserving this for the time of disease progression. The sequencing of treatment strategy, on the other hand, advocates using drugs with increasing efficacy on development of resistance or progression with first-line treatment, and thereby retaining the ability to offer a targeted drug at multiple timelines in the patient's illness. We are very well familiar with the acquired resistance to the first and second generation tyrosine kinase inhibitors, and it's not uncommon to see dramatic responses and having survival crossing a decade, or with looking at small cell transformation and again achieving good responses. But the real thing came 3 years back when Dr. Kumar and colleagues, Manita, I don't know if she's here, and they published this landmark paper of gefitinib alone versus with chemotherapy for EGFR-mutated population. And in the same issue, there was this NEJ009 trial, and you can see that it basically looked at the combination of combining simultaneously chemo and gefitinib followed by maintenance with both of the drugs. Almost identical patient numbers in both of these, median overall survival excellent in both of the trials, as was the progression-free survival. The important thing to note is that the Tata Memorial trial led by Dr. Kumar enrolled PS2 patients as well, which the Japanese trial did not. Response rates significantly better with the combination, and grade 3 or higher AEs also better with the combo. And this was the effect of differential efficacy. Now, this is a very busy slide. I don't even expect anybody to read it, but what I would like to say is that we have moved from an era where TKI monotherapy with first and second generation led to an overall survival in the range of 2 years approximately. Then, by using the third generation drugs earlier, this went another 12 months higher, up to 3 years. But when we are looking at these combination strategies, we are effectively looking at even crossing 4 years. And that is what we are going to discuss in the next 10-15 minutes. This is a summary of all of the data which is available. I'm sure you can spend hours trying to dissect all of the information here. So I'm going to go straight for the comments of the panel with a few cases. A 63-year-old lady, never smoker, homemaker, no comorbid medical conditions, presented with cough and shortness of breath for 9 months, fatigue and loss of appetite for 8 months, hemostasis for 3 weeks. A PET scan showed a right lower lobe mass along with right lower lobe and contralateral lung nodules, ipsilateral and contralateral lymph nodal disease, and space occupying lesion in the liver. A biopsy showed adenocarcinoma, non-small cell lung cancer, performance status 0, and this was staged as 4A based upon a solitary liver lesion. And therefore, chemotherapy was started pending results of molecular testing. And this is our in-house testing, which came in as EGFR and ROS1 negative and a PD-L1 TPS of less than 1%. And the tissue NGS was sent, and these are the results. And just to highlight, if in case it's not visible, there was an exon 18 mutation with a VAF of 26% and a TP53 coexistent mutation, as well as 2 other EGFR variants which were labeled as variants of unknown significance. So I apologize for it being very blurry, but this is the summary of the NGS analysis. And so we'd like to start with the panel and suggest that what would be this approach, given that the patient is on chemotherapy and an uncommon EGFR exon 18 mutation G719A has been picked up. I think we'll start with the Akhil.
So we are seeing a patient here with EGFR exon 18 mutation, which are still most of the time sensitive to the EGFR TKIs. But what we'll like to do here, since it is an uncommon mutation, in the same trial, the TMS trial, we included such patients where chemo plus gefapixant was utilized. So based on the available database, I would like to continue chemotherapy and add gefapixant to this patient. So that is what we would like to do. Now we have the safety data of at least OC plus chemo. If OC would like to cross-check whether OC multiple is active on this mutation or not. If it is active, that can also do. So chemo plus one of the TKI that we do. That is my choice.
So given the available data for the uncommon mutations, afatinib as monotherapy is the best choice, but osimertinib also has efficacy. We now have data that you can combine osimertinib with chemotherapy. So for this patient, would you continue chemotherapy and add gefitinib, consider afatinib monotherapy, or add osimertinib to chemotherapy?
In such patients, based on just that afatinib has overall approval for rare mutations, I do not consider afatinib to be the best drug actually for all the rare mutations. It might be a good drug for S768I. It is not a very good drug for other of the rare mutations. So I would like to utilize either chemo plus gefitinib or chemo plus osimertinib. If there is any data that osimertinib is sensitive to this mutation, I would be adding osimertinib plus chemotherapy in such patients. That is my idea. Vijay?
I would agree with we had affected uncommon mutations 2 years back, and at that time we looked at the data, exon 18 mutations, afatinib data alone did not seem very encouraging. So I also would be tending to go with the chemo plus a TKI combination.
Afatinib is not very good tolerated drug, so chemo plus afatinib might be very difficult. Yes. So that is out of question. So I will not shift to afatinib in this patient.
Dr. Kumar,
you have multiple options. I think so. What we ultimately choose in the clinic, what we are comfortable with, and the comfort level for us for TKI plus chemotherapy is such that, and we use the majority of our patients, at our center and across the country, they use this. That's the reason you are seeing this response. But I'm sure others will have an opinion of what you are suggesting. Those are the TKI and the combination. Those are all fair options, but these are something which we use and they are decent data to it. Number will be similar based on which afatinib got the approval. Afatinib didn't get approval based on some separate trial being done. It was a part of a subgroup analysis where it got the approval from. So again, there's a fair basis for people choosing this combination to what people are suggesting. But I do concede others will have some other options.
addition of NMETs?
No.
That would be one more point if NMETs are there.
Yes.
It will be different.
Correct. Dr. Natasha, you can give the international perspective.
So, I think I agree with all the comments, and I absolutely agree with Dr. Kumar. There are options here. And you do want to introduce a kinase inhibitor as quickly as you can. Certainly based on some structural data from MD Anderson for the G719X, we would offer afatinib. So we would switch this lady, but I think what's really nice about the chemo TKI combinations, whether you use 4 or 2, or what Dr. Kapoor's team developed, is that she's really high risk, right? She's got a TP53 co-mutation, it's a compound EGFR mutation, it's not just uncommon, right? She's got 3 different alterations there, and so her prognosis is going to be worse than a patient who just had even at 719. So, in Canada, we would just switch to afatinib, but we would have a discussion, and of course, this is a patient with intensified therapy, it would be very important to discuss.
Yeah, I think so. The take home from this is that even though there's an uncommon EGFR mutation, it's not the sole thing there. You have a TP53, which portends a poor prognosis. You have 2 other variants of unknown significance, and therefore the treatment of choice here would be combining chemotherapy with a TKI, and based upon the comfort level, you could do chemo gefitinib or chemo osimertinib based upon resources and patient preferences.
I agree with you. So that combination of uncommon mutations making a group, that happened because of afatinib wanted a label. The moment, and what Dr. Natasha was suggesting, that make this combination, this becomes far more uncommon. Put P53 there, put P10 there, and then put EGFR there. Any of those combinations will be uncommon again. But having said that, yes, they had a label for it, and that's why we always hear afatinib again and again in our discussions. But remember that this is a sensitive mutation where there are more than one option.
I agree. I actually kind of disagree entirely, Dr. Kapoor, because I don't think that all uncommon mutations are the same. So I think that 768I and 861Q, those tend to be more sensitive to drugs like osimertinib. 719, I think is a challenge. I think there is sensitivity to all of the kinase inhibitors, but again, I think it's more of a PAC mutation. And so some of these second generation kind of nasty inhibitors, I think, are an option. But I also think tolerability is important. Nobody likes afatinib. So if you're able to use one of these other drugs like osimertinib or gefitinib, that's also good. But I think there are growing data, I think, from Asia, from the Koreans and others, that not all uncommon mutations are the same or can be approached with the same TKI.
Okay, so in interest of time, we'll move on.
Can I clarify? I was saying the same thing. I was saying that this was clubbed together for FDA label, but they're not the same. So I was saying the same thing. They are different, but
right. So 68 years old gentleman, never smoker, comorbid medical conditions included hypertension for 10 years, benign prostatic hyperplasia, left hydronephrosis with ureteric calculi, and presented with cough, shortness of breath, hoarseness of voice, and weight loss. A PET scan showed a huge 10.5 by 8 centimeter left upper lobe mass with mediastinal invasion and involvement of the superior vena cava and right main pulmonary artery and ipsilateral hilar and mediastinal lymph nodes. Bronchoscopy showed a growth in the right main bronchus, and biopsy showed adenocarcinoma. Performance status 1. Stage was T4N2M03B, and this patient had been on urinary catheter for 3 weeks for urinary retention. He was planned for a urological procedure and was cleared by us with an increased risk for perioperative pulmonary complications. And in the meantime, the tissue NGS came, and the analysis in front of you, to summarize, it's an exon 19 deletion with a VAF of 21% along with a SMAD4 exon 19 mutation, which is VAF of 19%. And so, given the scenario, what would you do? I'll start with Dr. Samil. What would you do first?
Non-metastatic patient.
Yeah, non-metastatic 3B.
Yeah. So
on a urinary catheter.
So first, I would like to discuss with the radiation oncologist whether we have a possibility or not. If it is, then that. If it is not, then definitely the EGFR target therapy will be option here. Again, there is a mutation, SMAD4. So in that case, I would like to see whether osimertinib alone would we have seen efficacy or not, and accordingly I will take the decision.
Vijay Patil.
This size of the lesion is 10.5 to 7.7. There's mediastinal invasion. this SVC involvement, LPM, and that is 2R, 4R, and 7 lymph nodes positive. I'm not very sure the radiation oncologist would be in coherence for taking this patient for local therapy. So in practical, in a multidisciplinary tumor board, this would be coming for a palliative systemic therapy, at least initially. After the response assessment, things change quickly. Looking at the patient is 68. He has a BPH, there's left hydronephrosis, there's ureteric calculi. In this patient, I would stick with osimertinib only.
So any differences, Dr. Natasha, Kumar?
No, I think we spend a lot of time in North America, I think, trying to cure incurable stage 3B disease. And so someone will stand up in rounds and say, oh, we should give this man chemo radiation design that, when you know you're not going to cure him and you know you're not going to help him. And so I think the real discussion with the patient is, whether this is curable. I think it's probably not. And then, of course, the much nicer option is osimertinib. It's more challenging with someone who potentially could be cured by chemoradiation and has an EGFR mutation. Then the discussion is much harder. We have this nice, easy treatment, but it won't cure you, or we have this, more challenging treatment which may cure you. But yeah, I agree with the team. I don't know, Dr. Kumar, you give osimertinib as well?
I agree with you.
Right. So again, when you are assessing a patient for combination strategies, you have to factor in everything, the comorbid medical conditions. So the disease stage is one thing, and the actual fitness for the therapy is another stage. Moving on, 38 years old male, a shop salesman by occupation, never smoker, no comorbid medical conditions. Presented with cough, chest pain, and constitutional symptoms. A CT showed a 4x4 left upper lobe mass with nodules in the same lobe, and ipsilateral hilar lymph nodes, squamous cell carcinoma on bronchoscopic biopsy. We thought the provisional stage was 3A, but a PET CT showed it to be actually 4B with metastasis in bones, abdominal lymph nodes, and cervical lymph nodes. Very good performance status 0. And this patient was started on paclitaxel cisplatin based on the report of squamous. I have to admit here that the squamous was not confirmed by immunochemistry. But since this was a never smoker young patient, we went ahead, did testing, in-house testing was negative, and this was tissue NGS, which showed an L858R exon 9, L858R exon 21 point mutation with a VAF of 1.08%, with a rider that this has been detected at an elite percentage below the limit of detection. So Dr. Natasha, I'll start with you this time. Would this patient go on to a combination? What would you do?
So I think it's a great question. He's young, he's got significant disease. Should we be more nervous about squamous patients? We don't know. He's got L858R, so are kinase inhibitors alone enough? So, certainly talk to him about intensifying a FLAURA2 type approach or one of the other combination approaches. In Canada, though, it would be 50-50. Some people would intensify and some people would just start them with. So we'll go with
Kumar?
So I think so. We don't have separate data analyzed for squamous cell EGFR for TKI plus chemotherapy, but TKI data we had the cohort where we could show that giving TKI is useful, and yes, I don't have any reason not to intensify. Usually in MTB at this moment, we do intensify if patient can tolerate it. I think so. Vijay is there, he has been part of MTB, he can also comment on that.
My question is, would you add the TKI to this current regimen, which is Pacli-Cis, because it was started on the basis of the squamous report. I admit it may not be truly squamous, it may actually be an adeno, but given what you have, what would you do?
No, let's take squamous. I'm answering, taking a presumption of squamous here. So the question about, first question is the safety. So there's a good data regarding taxane. It started from long back, 2004-5. This data is there for taxane with TKI. Those are all negative studies, but they showed that it is safer to combine. Second, the concept, the trials which answered for EGFR plus TKI plus chemotherapy was, is chemotherapy adds value? And we do know that in that the value addition is primarily by the platinums. There is a trial for pemetrexed alone combined with EGFR TKI, but if you see data a bit more closely, it looks like combination has got some more value. So it looks like platinum is adding here. So your platinum is here. Safety data is here. In this situation, you're not going to get a randomized trial today or in the future. So combining is possible, and it is better to combine.
And I would get a pathology review. I think you
Yeah.
highlighted a good point.
We've actually done that. We've told our pathologists that, okay, this was a squamous report, the in-house testing was negative, but this is the NGS we just picked up, and the final sign of squamous did not include immunochemistry. But what you do to go and look back and tell whether it's true squamous, or are we missing out an adeno component here?
Maybe using a weekly regimen may be a wiser option here.
I'm sorry.
Of chemotherapy, weekly regimen of chemotherapy rather than 2-3 weekly. So that neutropenia thrombocytopenia will be less.
You're saying shift to weekly regimen and add Gefitnib. Okay, we could do that. Okay, we have 4 minutes and we have a few more cases. 63-year-old lady, again homemaker, never smoker, hypertensive for 15 years, presented with cough for 4 months, shortness of breath for 1 month, right malignant pleural effusion, TDF1 positive, bilateral lung nodules, stage is T4M0M1A PS0, and the EGFR testing from the cell block showed the presence of an L858R and an exon 20 T790M at baseline. A simultaneous liquid biopsy ddPCR confirmed that both of these mutations were present, and this patient was minimally symptomatic. The treatment decision was deferred by the patient and family till both of these reports came in. MRI brain was normal, osimertinib was initiated. There was partial response on repeat imaging, which was in approximately 3 months from treatment initiation. She was clinically stable, in fact largely asymptomatic, and serial imaging continued to show sustained partial response. In fact, it was almost like a complete response. There was asymptomatic progression in October of 2021, which is 44 months from initiation of therapy, and this was largely because of the increase in the size and the number of nodules. And at this point of time, a liquid biopsy NGS was done, which did not pick up anything. So,
Lesions big enough to biopsy?
no.
Oh.
And so that's what I'm saying. So osimertinib was continued as treatment beyond progression. And the plan was to get a re-biopsy whenever the patient was billing and it was technically feasible. And so February of 2022, she had symptomatic progression, was shifted to a second-line therapy, which was PEM-carbo and Gefitnib, stable disease and repeat imaging, and went on to maintenance pemetrexed and Gefitnib. Again, progression in approximately a year's time, and this time the pleural fluid increased, and the cytology was adenocarcinoma again. We did a thoracoscopic pleural biopsy, which confirmed it to be adenocarcinoma. It was sent for NGS, but unfortunately there was a QC failure. ECOG performance status of 1, and third-line treatment was given with erlotinib and bevacizumab, but there was only a PFS of 4 months from that time. At this point of time, another liquid biopsy was done, and this shows just the L858R mutation with a VAF of approximately 5%, and nothing else has been picked up. So given this scenario, and if such a patient were to come in today's era, would you still do osimertinib alone, or would you do osimertinib plus chemotherapy at the beginning?
So she's had osimertinib, she's had platinum, Gefitnib, she's had erlotinib and bevacizumab. I mean, I think a different approach is now needed. I think just because the EGFR mutation is present doesn't mean that the tumor is necessarily going to respond to further kinase inhibition. I think the big issue is we don't know what the mechanism of resistance is. So you do wonder if this is a person who might benefit from going on to a trial with one of these sort of targeted, untargeted approaches. So maybe talking about Brextican or DXD. If you get them on a study with that, that might be a good option. And I guess, again, the mechanism of molecular resistance is really unknown. Docetaxel also.
So she didn't, we gave 1 second, she didn't tolerate, unwilling for further, and she's almost 6 years from diagnosis and PS2. So the question is, what would you do? Your all attempts at getting assessing molecular mechanism of resistance have
I mean, we try to get these patients on trial, things like gamma laser or things like the DXD, although we worry that she can tolerate docetaxel, she's not going to tolerate the DXD. But certainly this is an area of unmet need, and there's no standard after this for anything like this. What do you guys do for center for someone who's fifth line now?
Vijay, any choices?
They probably offer amivantamab.
Sorry? That.
Why not to use
Take some amivantamab with any marker in this setting and show some decent responses.
Well, we have some data. It's not great, but we're doing a sub-Q study, and I'm always surprised by the benefits. But it is the sort of nth line, but there are no published data yet. I mean, hopefully there'll be published data next year, but it's sort of an nth line trial.
Okay.
So would you try that sintilimab plus chemotherapy? Sintilimab did show some.
Orient study or something?
Do you mean, so I think the IO plus chemo data are less strong, but I think that if you add a VEGF inhibitor that's stronger, I guess the question is, what's the value after she's failed bevacizumab? Do we think that there's some resistance there, or do we think that the VEGF inhibitor just, enhances what's already going on? And I do worry about this lady, right? She can't handle docetaxel. Can she handle Empower 150 or anything similar? So
I mean, she was PS1 for a long time and now has become PS2. I mean, she's 6 years from diagnosis. In a way, has done remarkably well, but we still don't know the mechanism of resistance. She's had 3 liquid biopsies, 2 biopsies. You can't always find what you're looking for.
No, and I mean at that point, you just have a very open conversation. There are no data to support anything at this point, and then you just pull whatever you have out of a hat, whether it's a trial, or the patient goes and buys her own TKI again. It's, I don't know, what would you guys do?
I guess that's why we are reflecting on someone to take in questions. So Apar is there in the audience, why not ask him?
Where is he?
So this is the one question we are all reflecting on, someone who can take it up. So we thought you are in the audience.
I can see
This patient, what you will do?
So she's failed an EGFR inhibitor, bevacizumab, and not tolerating docetaxel.
She's already received multiple lines.
Yeah, she's had OC, pemcarbogefitinib, then she's had Erlo-RAM, or Erlo-Bev, and she's had 1 cycle of docetaxel. And so we talked about trials.
Some TKI or docetaxel, paclitaxel weekly, irinotecan, some data from Japan which is there.
So does mine. You could use
Amivantamab also be suggesting.
vinorelbine or irinotecan, like you said. Weekly vinorelbine I found well tolerated at dose of 20 to 25, but I don't see any good options over here. Sorry.
So you cured her. Are you going to show us the next slide? No? What did you do?
What did I do? So I think she came last week, I think, and so we discussed. I mean, I think she says no more chemo, that's for sure. She's still okay with doing a TKI. She had a lot of biopsies and doesn't want any more this thing. So we gave her that the only drug which may or may not work and which is oral is dacometinib. And she's agreed to try it at 30 milligrams. We don't even know whether it's worth it or not, but it is either stopping treatment or maybe if she agrees weekly chemo. She's had this bad experience with docetaxel, and we just have to, we are out of options basically.
I don't see any point in utilizing further TKI.
I agree. So basically the EGFR mutation is still roaming around, it is not really driving the tumor. And so if you,
Was it maybe it can be right.
Although clearly, we've got such disparity here and zero evidence, supportive care is probably the best thing for her, which is very sad. But a lot of my patients, even when they go to hospice, they still take a TKI. That's not right, but that might be an option. Definitely.
okay, we are out of time, right? Or do we do one more quiz? No. Okay. So thank you. We have another 2-3, but we'll keep it for the next discussion. Thank you so much.